Good day everyone, I'm Angelo Agapay. Today, I'm going to do the neck assessment. So first, beginning with inspection. So sir, can you lower your gown? The patient's neck should hold erect and mid-line. It should have symmetrical muscles and no swelling and masses. If there's swelling below jaw angle, palpate the area to check a thoracic gland problem. Check neck's active range of motion by having the patient touch his chin to his chest. Turn his head to the right and left. Tip his head towards his right shoulder and left shoulder and tilt his head backward. All these movements should be smooth and painless. Sir, can you touch your chin to your chest? Okay. Sir, can you please move your head to the right and then to the left? Sir, can you please move your head backward?
Okay.
Assess the spinal accessory nerve. Apply resistance to the patient's shoulders as he shrugs. The shoulder muscle should be symmetrical and able to overcome your resistance. Sir, can you overcome my resistance? Turn his side to one side as you apply resistance to the side of his chin, vice versa. Note the contractions of the opposite sternal-mastoid muscle and the force of the movement against hand. Movements should be equally strong. Next, move on to the lymph nodes of the neck. With the finger pads of both hands, bilaterally palpate the nodes using the circular motion. Palpate the lymph nodes in sequence. Preauricular, posterior auricular, occipital submental, submandibular, occipital, submental, tonsillar, superficial cervical, deep cervical chain, posterior cervical, supraclavicular. Note the size, shape, consistency, mobility, and tenderness of the nodes. Normally, the lymph nodes are smooth, soft, non-tender, and movable. If there's swelling or tenderness, search for possible cause. Jugular veins using tendential lightening with the patient supine and his head elevated 30 degrees and turned away from the north. Internal jugular veins may be possible. They should undulate softly and decrease in inspiration. Note unusual prominent pulsation. Sir, can you move your head to the side? Now, the patient sitting up. Identify the trachea by locating the external notch and sliding the finger of each side of it. The trachea should be midline and symmetrical. Stand in front of the patient. Use the fingers of the left hand to push the thyroid gland to the right. Curve the fingers of the right hand between the trachea and sternocleidomastoid muscle. The nurse should feel the thyroid. Stand in front of the patient. Use the fingers of the left hand to push the thyroid gland to the right. Curve the fingers of the right hand between the trachea and the sternocleidomastoid muscle. The nurse should feel the thyroid as the patient swallows. Then, palpate the thyroid gland from behind. Place the fingers, both hands, on the patient's neck with your index finger just below cricoid. Palpate both lobes and the isthmus. Instruct the patient sip and swallow during the exam. Note the size, shape, and consistency of the thyroid.
Thank you po.
Can you sip the water? If the thyroid is enlarged, auscultate for bruise with the bell of the stethoscope. A bruise is a blowing sound caused by turbulent blood flow. Observe the carotid arteries for possible pulsations. Gently palpate the carotid artery using index and middle finger. Palpate one carotid artery at a time. Otherwise, you could block blood flow from the brain. Don't press too hard over the carotid sinuses located high in the neck because this could cause vagal stimulation which could slow the patient's heart rate. Have the patient take a deep breath and hold it as you listen to the carotid artery with a bell. There should no bruise. That's all for the neck assessment.
It's in it?
Thank you. It's it. So now I will assess the thorax respiratory system, starting with posterior back. To assess the thorax, ask the patient to breathe normally as you observe his respiration. Respiration should be regular and symmetrical. The accessory muscles should not be used. So sir, can you breathe normally? Okay. Move to the back of the patient, assess the anteroposterior and lateral diameters of thorax. Normally, the lateral diameter is up to twice the anteroposterior diameter for a ratio of about 2 to 1. Use finger pads to palpate the spinous processes. They should be evenly spaced and non-tender. Next, assess respiratory expansion. Place your thumb at the level of thoracic vent. Sir, can you take a deep breath slowly? Next, assess tactile premotals or voice sounds palpated in the chest wall surface. Using the ball of the hand, feel for vibrations as the patient says 99. Move from the apices inside the scapula down to the lower and lateral thorax. In each location, there should be equal vibrations. Sir, can you say 99?
99. 99. 99. 99.
Perform mediate percussion using systematic patterns to compare the two sides. Resonance should be equal over the lungs. You should hear dullness over the diaphragm. Hyperresonance means you found area of increased air in the lungs or pleural space as with normal thorax or acute asthma. Abnormal dullness indicates decreased air in the lungs as without the build-up colossal fluid. Now assess the patient's diaphragmatic exertion. Ask the patient to exhale and then hold his breath. As he holds his breath, percuss from the scapula down to where the sound changes from resonance to dullness. Marks the specific spot with a pen. Normally, the diaphragmatic excursion measures 3.5 cm and it's equal on both sides. Next, assess the kidney using blunt or fixed percussion over the costal vertebral angle. Percussion of this area should not cause tenderness. Finally, auscultate breath sounds with the diaphragm. Instruct the patient to breathe deeply through his mouth. Started at the lungs, A to Z, auscultate the lungs and move from side to side down to the patient's back and laterally the axillae. You should not hear bronchovesicular sounds between the scapula. This sound is moderate in pitch and amplitude with an inspiratory phase equal to the expiratory phase. Sir, can you take a deep breath through your mouth? You should hear vesicular sounds at the apices down to the bases laterally. This sound is low pitch and soft, longer inspiratory than expiratory phase. Listen for abnormal sounds such as crackles and wheezes, and for coughing and abnormal respiratory effort. If you hear crackles or wheezes, ask the patients to cough and listen again to determine if the abnormal sounds is cleared. Sir, can you please cough? Okay. Crackles, which can be heard in inspirations and sometimes in expirations, results in collapse or fluid-filled alveoli popping open. They have bubbling sounds. Wheezes, which can be heard in both inspiration and expiration, are high or low pitch. They indicate airway conduction. To assess the patient's anterior thorax, begin with the bones and muscles. Normally, they appear symmetrical and there should no accessory muscle used. The patient should not have the sign of respiratory difficulty such as sinuses or nostrils flaring. Next, palpate the thorax with your finger pads, moving to the lung apices to the bases. To assess respiratory expansion, place your hands on patient's chest along the costal margins with your thumbs pointing towards the xiphoid process. Sir, can you take a deep breath slowly? Now assess patient's tactile primotus as the patient repeats 99. Move to the lung apices down below the nipples. Comparing sides, vibrations should feel equal but stronger in upper chest than to lower chest.
99, 99, 99, 99.
Percussion should produce low resonance sounds. Next, perform percussion over the lungs using systematic approach. Start just above the clavicle. Then, auscultate over the patient's lungs with the diaphragm you used. Over the lungs. And tracheal sounds over the trachea. These are high pitch and fibular. You should hear bronchovesicular sounds laterally and over the bronchi and the angle of the Louis. Expect the vesicular sound at the most of anterior thorax and the periphery. And that's all for the thorax respiratory assessment.